We are back again with a controversial issue this morning about the left atrial appendage occlusion, indication and techniques. And this is a controversial issue, but the problem is important because, as you can see from this slide, the ischemic stroke, which represents the most part of strokes, changed the epidemiology in the last few years. Before 205, most part were coming for the large artery burden atherosclerotic. Nowadays, also because of very aggressive intervention on the carotid artery from our vascular surgeon, the most part of ischemic stroke, as you can see here, come for a cardioembolic problems. And mainly the cardioembolic problems come for the aging of the population, from atrial fibrillation that we know over 70 years of age can be present in 4% of the population. Now we know also that with the new anticoagulant, the hemorrhagic risk that was linked to the warfarin is much decreased, particularly for hemorrhagic stroke and for intracranial hemorrhage, and this is very important because it has the most worrying bleeding problem. We know also that anticoagulants have a lot of limitations. The first of all, there are contraindications that in 2 cases are absolutely contraindications, in 8% are relative contraindication. But more than that, the adherence, which is the percentage of the prescribed dose of the medication actually taken by the patient. If you need 2 pills, then you have to take 2 pills, or every day the pills, is around, even with the new anticoagulation, is around 78%, and the persistence, which is the patient still in drug after a certain period of time, as you can see, is also not much. 70% at 6 months, 60% at 1 year, even in the randomized trial that, for example, that in our hospital we did it, only 80% are still in anticoagulant after 1 year. And we know that not taking anticoagulants is increase the risk of stroke. If you have a CHA2-VASc 2 or 3 after 6 months, but if you have a CHA2-VASc more than 3, then your risk stroke, if anticoagulant is stopped, arrive just after 1 month of suspension of anticoagulant. Also, we know that all the thrombus come from the left atrial appendage, 90% in this work, but most part of electrophysiologists, or the one who close the appendage, think that almost 95% come from the left atrial appendage. Now, the left atrial appendage have a various morphology, are not all the same. Various morphology, the most frequent one is the chicken wing, as you can see here, that account for 45% of all the appendix morphology. Then come windsocks, cactus, cauliflower is quite uncommon, almost 10% of the cases. And we know also that the different kind of appendage carry a most important risk. Having the chicken wing, the less risk for forming thrombi inside, while the non-chicken wing, particularly the cauliflower, are very important because, of course, there are all these small muscle here that can entrap the thrombus inside. Now, why then, if it's so clear that come from there, then we have the way to close the appendage? Still, the guidelines, American and European guideline, put the closure of the left atrial appendix as 2B, in class 2B. and means that left atrial appendage occlusion for stroke prevention is indicated for in patients in which there is contraindication to anticoagulants. Well, we know now, few weeks ago, came out the APCI expert consensus statement on catheter-based left atrial appendage occlusion. And I just want to go with you through a small consideration coming from this statement. This statement comes after a lot of consensus document, 2016, 2017, this is the Italian one, this is the APCI document, this is the Munich document from Germany, in which already they settle a kind of patient that can profit from the left atrial appendage closure, which are, beside the contraindication, advanced chronic kidney disease, patients with contraindication to the triple antithrombotic therapy after PCI, reduced compliance, stroke on anticoagulants. Now the document, this document, the most recent one of the European Society, go a step forward. Why? Because, of course, here you have the contraindication to oral anticoagulation. Here you have the elevated bleeding risk patient, more than 3, elevated risk outside as black score, tumor, need for prolonged triplet therapy. But here there is another thing that is underlined in this document, which is patient unwilling or unable to take anticoagulation. This is the first time that appear in a consensus paper. That means that you will propose to your patient to have NOAC if they are in atrial fibrillation. If they accept, they go in NOAC. If they don't accept, they are unwilling to take any anticoagulation, then you are allowed to propose left atrial appendage closure. And so probably the panorama, at least in Europe, will change. This is a survey done in Europe 2 years ago, 2017, and you can see that in our countries, the most part, 90% of procedures are done because of contraindication to anticoagulation, and this probably will change after this document. That's why we are so in doubt in enlarging the indication. But well, because still we have now more than one, more than 2 devices to close the appendage. However, the randomized trial that we have are still the 2 trials, and one more that will give you some insight, 2 on warfarin, PREVAIL and PROTECT-AF, and from these 2 trials, 2 randomized trials, we know that compared to warfarin, Watchman is equivalent for total stroke, is inferior for ischemic stroke, but not reaching statistical significance at 5 years, is superior for hemorrhagic stroke, is superior, and this is very important, for cardiovascular mortality. If you see so, you can see that ischemic stroke still favor warfarin, but because of hemorrhagic stroke is so striking in favor of left atrial appendage closure, in the end, all cause of death are for the closure. And if you take the ischemic stroke, if you take out the procedure-related strokes in these 2 trials, you will see that there is no difference between Watchman and warfarin as far as ischemic stroke are concerned. Now, I show you briefly the study. Is not yet in the paper, but you will see it in the paper. I am not sure if it's in New England or in circulation in the next in the next few weeks. This was presented in the European Cardiac Society of Cardiology end of August, and is the Prague study. Why is important? Because it's the first and the only study that compare closer with Watchman to new anticoagulant, and is not a sponsored trial. This is a trial done by the University of Czechoslovakia, 16 centers, and they include all the patients with non-valvular atrial fibrillation with a history at high risk for bleeding, either history of bleeding requiring intervention or history of cardioembolic events taking anticoagulation, or a CHAD-VASc more than 3. Randomization 1-to-1, you can use any new anticoagulant, preferred apixaban, and left atrial appendage occlusion with amulet, most with amulet, or with Watchman, 35% with Watchman. And then outcome: stroke or transient ischemic attack, systemic embolism, clinical significant bleeding, cardiovascular death, and significant peri-procedure problem. 201 patients in each arm, and here is the result. As you can see, there is no difference in the primary composite endpoint in intention to treat population between the left atrial appendage closure and the new anticoagulation. This trial is not definitive yet, but at least you can say to your patient that if you take a new anticoagulation or if you close the appendage, there is no much difference in the end of the story. This is as far as all stroke and transient ischemic attack are concerned, and this is for cardiovascular death. Of course, when you go to the bleeding risks are much higher with the anticoagulant than with NOAC. But this difference doesn't impact on mortality. Now, coming to the technique, in order to improve even more our results, it's very important to do. I want to underline just two things. When you close an appendage, first of all, you have, as you do for the clip, when you put a clip, you have to pay attention to your transseptal puncture. Why? Because particularly with the new devices, it's very important to come in the mouth of the left atrial appendage straight, you see? Not in this way, in which you end up here, and then you have to turn your catheter a lot within the appendage. So in order to do that, you have to do your puncture under transesophageal echo in order to see the trajectory between your puncture and the appendage. Now we have a lot of new catheter with anterior, double curve, single curve. You will see also this in this document of the European Cardiac Society. In order to enter your appendage in a proper way, so you don't have to turn inside the appendage your catheter. And this is different from this device, which is one of the most important devices, in which you have to enter here in order to opening your first disc inside the appendage. Even more important with the Watchman. Now, Watchman, I just wanted to tell you that the improvement, I know that the Watchman Flex, you don't have it yet in Egypt, but the company told me that probably in 6 months, 1 year, you will have it. Now, the new Watchman is much safer than this one. First of all, you don't have to put the device very deep inside the appendage because it's shorter, because the maximum depth is half the device size, while here the maximum depth was equal to the ostium of your appendage. So you have to go very much inside the appendage. Then there is more hook, you see, in order not to lose your catheter, and then you have more size. And then this size forgive you because for the same size you can cover a range, for example, for 24 you can cover a range between 19 and 26. So you are forgiven if you are not completely precise in the millimeter. I show you a case just to show you how is important the amelioration of the devices. An 80-year-old woman, hypertension, diabetes, previous stroke, PCI with death on left main, LAD, circumflex right coronary, in end-up, plus NOAC, having an important severe anemia treated with transfusion coming from the gastrointestinal apparatus, CHADVASC 7 and has bled 4. Now we decided to go for the closure of the left atrial appendage, and as you can see here, this is a chicken wing, a reverse chicken wing appearance of the appendix. And in this case, of course, if you go with a device like this, you have to enter in the wing of the appendix, which is quite difficult to do it, because you have to really put your guiding catheter, your sheath very, very far. Now with the new, you can see here, you have to go through here. While with the new Watchman Flex, you can have a much safer procedure, because you can aim to go to the shoulder and not to the wing of your chicken wing appendage, and you open these balls, which is much more flexible than the other one, and you can really do the procedure quite safely and quite quickly. You can see here the procedure is almost completed. Then you can do the measurement of your shoulder, your compression measurement, and then the procedure is finished. Now, we know that we have a lot of success, particularly nowadays with these new devices. And in the evolution, you have 98% of success. In the commercial, 95%, even with 70% in the commercial of new operator. In Prevail, with 50% of new operator, 95% success. So it's a procedure, and this with the Amplatzer, the other one with the Watchman, with the Amplatzer, again, you can reach 97% of success. But still, we have complication. How we face the complication? Now, complication came down. You see from the PROTECTA-F, 9% of complication down to 2.7 in the evolution, more than 1,000 patients. But still, we have some complication, because even 2% of complication, if they are serious complications, are too much. Complications go down with the experience of the operation, of course, and with the experience of the center. You can see here, for example, there are some complications that really disappear. For example, device embolization, extremely rare. I don't remember a device embolization since the last 5 years. Why? Because we know how to implant it, we know how to do the proper measurement before the implantation, and we know not to do vigorous tag testing when you implant it, so it is extremely rare. However, the pericardial effusion stays there as a complication in more or less 0.8, 0.5, 1%. And I have to say that this complication is also very common in the electrophysiology department. They have 0.5, 1% of perforation. But here, the perforation can be acute, and then you can deal with the perforation in acute. We know how to deal. We are used also in the coronary. But you can have also a late perforation because the appendix is very thin. You can see here, there are a very thin wall. So if the device is too inside or is too big, and then can hurt the wall of the appendix, and then you can have a late perforation. Second thing that is important is ischemic stroke during the procedure. Now, I have to say that more or less 5, even 10% of the patients who come on the table for a closure of the appendix have a thrombus in the appendix, and we cannot close because there is a contraindication to go there because the mobilization of thrombus can be very important. Of course, air embolism, we know that with the big catheter, 14 French catheter, we have this problem. We have just to pay a lot of attention. But sometimes when you are in this situation, you cannot avoid not to close it. And this is a case, 87-year-old man, permanent atrial fibrillation, hypertension, intraparenchymal cerebral hemorrhage. Ventricle was good, however, beside in the apex of the left ventricle, but particularly inside the appendix, in the apex of the appendix, you can see a sort of, you can see here a sort of thrombus. Now, in this case, when you cannot give any anticoagulant, and when there is a very high risk of ischemic stroke, then you can use, again, this is another chicken wing, you can use this. You can use a cerebral protection. This is cerebral protection. We start to use it for the aortic valve replacement, for TAVI, no? But we can use it also in this situation, and this, what you do is very simple because you put from the 6 French from your right arm, and this is what we did, and you do the procedure. Already we have done 6 cases in this way, and you do the procedure. You can see here one filter is positioned into the left carotid and the other one in the right brachiocephalic trunk, and you do your procedure with your heparin, and then in the end of the procedure, you do the procedure, in this case, again, a 24 millimeter because oversize of 30%, 24 millimeter because this was 19, the opening of the appendage, and here you can see your shoulder, all the measurement, no pericardial effusion and discharge, and we take the filter 5 minutes after the procedure. Now, the only thing that I want still to underline to you is the delay from the device thrombosis, because this is not a small problem. In all the series, the device thrombosis range from 1.2 to 7%. 7% was in the French survey with a lot of cases, with a control arm, with a control at 3 months with the transesophageal echo. So it can be a problem because when you have a thrombosis on your device in the weeks or the first few months after the implantation, then is associated with a higher rate of stroke. You can see that the rate of stroke is higher, and you can also know which are the patients in which is more more easy to find a stent thrombosis, the old one, previous ischemic stroke, the one had a very important smoke in the atrium, and the one, and you can see that if they have a thrombosis, then the ischemic stroke, the percentage of stroke in the future is increased, and this is an example. So how to face the thrombosis post-implant? First of all, we know that after the implant, the only treatment is with single DAPT in aspirin probably is not enough. In fact, in the French registry, in which the device thrombosis was 7%, most part of the patient were in single antiplatelet treatment in aspirin. The second thing is that the evolution registry at 1 year had shown that the double is finished. The double treatment is also bring you quite a lot of hemorrhagic complication. So what to do? I think also in the paper of the European Society, there is no a definitive answer. I think we have to go back to be a good doctor and to see patient by patient the risk of having 3 months of anticoagulation or 3 months of double antiplatelet treatment against the risk of hemorrhage giving only aspirin even in the first 3 months. Leak is not a problem, so the conclusion is that the patient at high risk at CHA2DS2-VASc score who had contraindication to anticoagulation, high bleeding risk, low adherence anticoagulation, or willing not to have it, and new stroke during medical advice. And of course, you have to be extremely careful and having a good training in order to lower your complication at the minimum. Thank you for your attention.